Hey, Carrie,
Yeah,
I don't have in front of me the notes about which side is which. So do you have it in front of you?
I know I start at 15
You do or
and
I
that
do?
I do. And I know
Okay.
when I hand it back over to you.
All right, perfect.
All right, good afternoon, everyone, and welcome to our first learning forum for 2026. This is for champions only, so welcome all. And I will mention that we are recording. Um, you're welcome to stay or leave if that is a problem. And I'm going to turn it over to Tara to get us started.
Hi, everybody. Happy 2026. I am thrilled that you all have made the time again to join us. Again, I've said this before, I'll say it again. Taking time out of your day to connect, especially as the champions of your hospitals and your clinics, is not lost on us. And so, thank you. We really think that there's value added in just meeting with the champions. And we're going to do that this month and next month. Return to our KPQC wide listserv and membership the following month. But certainly want to use this time for you all to provide feedback or ask questions as much as we want to get information out as we head into the next year of our bundle. Next slide. So we like to show graphics just so that you get a feel and a vibe of your colleagues working on the same things throughout the state. The 39 red hearts are the birthing facilities enrolled in the severe hypertension bundle, and the 11 blue hearts are the non-birthing facilities. 50 strong, and you all look at how far the expanse is. And to hear your stories are invaluable in terms of where you are in the state. We also know you're connecting dots with each other, and that's pretty awesome stories too. Next slide. Our next big in-person workday is now scheduled. We will be sending out calendar invites and certainly registration links very soon. This is a quote mandatory attendance for all enrolled facilities champions. And as you can see there, it will be on May 1st in Topeka. Those of you that have been enrolled before and attended our in-person work days or conferences know that Sunflower Foundation is a beautiful, easy to reach location right off I-70 in Topeka. And we're thrilled that they're letting us host again there. So plan to be there May 1st, 9 to 4. We would ask that at least one champion per site attend and bring one guest. So if that's your OB provider, if that's a second champion who's working on one of the initiatives with you, great. But that is our hope that we have at least two representatives from each hospital enrolled attending. It is for both birthing and non-birthing facilities. We're excited to see you there. So more information to come. Next slide. The severe hypertension bundle completion, just so it's on your radar, the end of this year, December 2026 is when we will be done with the current bundle. That means we've got a lot of work to do, but as you're going to see here in a minute, all of you have done a lot of work to get process improvement complete at your hospitals, and we're pretty thrilled to share that with you today. Next slide. We like to get out information, and in our team, we share a lot of current events, articles, posts, professional FYIs, to somewhat share out with you all, also to make sure that we kind of have a vibe about what's going on in the state and the nation. And there's a lot of information, certainly in the OB world happening, let alone the pediatric vaccination conversation. So, what this snapshot is in front of you is the KDHE birth report from 2024. As many of you know, the vital statistics reports that come through with birth certificates and death certificates comes 1 year after. So we're just now getting 2024 data. Really interesting information there. Again, the birth rate in Kansas is declining, and that's been the case for several years. It talks about adequacy of prenatal care and attendance at prenatal care. It talks about birth rates to certain demographics. And you can even drill down to your county specific data. And I think this is value added. I think it's helpful to know what's going on in our state, some trends that they're seeing, both good and bad, and also, again, to find out what's going on in your community. The link to that specific document is there on that slide, and you can find it easily on the website. Next slide. Also, speaking of websites, we have done some important work around our own KPQC website because we wanted the resources to be easier for you all to grab. The severe hypertension bundle comes with so many resources, links, articles, protocols that we wanted to hopefully have a one-stop or two-stop shop within our website for you to find all of that content. And so again, these are screenshots of our updated KPQC website. Under the Severe Hypertension and Pregnancy Initiative resources lists lots of drill downs, you guys, from the action items to the articles to the protocols, and specific pieces of the bundle. Also, Kansas specific information like the maternal warning signs, and other hypertensive articles that, for example, OB providers may want to find and see. So it links you to many other websites, but it also provides real-time protocols and needed resources that we think that you'll find easier to find. If you don't find it there, have questions, of course, reach out to Carrie and I, but we're hopeful that that's much more helpful to you. Next slide. I think, again, as we talk through our KPQC work, we would be remiss to talk about the hard pieces of our world, which includes stillbirth. And one of the things that came across my email this last couple months was a new toolkit for health professionals on supporting patients through stillbirth care. We know that we have several champions in our state that have really, really done an amazing job for many years. Yes, Brittany, I agree. On this work at the local level and even created statewide support services, as well as new protocols. And so I'm going to guess that ACOGS is about the same as their great work, but wanted you to know that it exists, and it's easy to find online. Next slide. I also like to find things, because I think in this direction too, of the current research being done surrounding high-risk maternal conditions, that helps me understand and communicate with patients and other providers and other clinicians about the unpackaging of why we see high-risk conditions happen. Are there some identifiable prevention items? What is the latest research in prevention and treatment? And I found this in one of the ACOG articles and thought it really helpful. So it's just in the slide. You guys take a look at it when you get this slide deck after our session today. But it speaks to the triggers for high-risk maternal conditions and anything from obviously placenta. We love that thing, but it seems to be a significant part of the problem on many of our high-risk conditions, to certainly the fetus and the integration of that response mechanism. So again, great slide. Hope it's helpful. Next slide. All right, let's go into our bundle updates. And again, we're going to ask for feedback and conversation through this. Carrie and I have tried to keep things as succinct as possible, but want to make sure that we have an update for everybody on what's going on. Next slide. Let me jump here. Carrie, I think you're on the next one. Is that right? Is this still my slide, Carrie?
Yes,
I'm going to jump. Okay.
this is still you.
Carrie has the notes. Post-birth seats, the relaunch. So you guys, if there was a better, most popular acronym in the last 4 years in this state, I don't know what it is, because post-birth and the education of providers, patients, triage, community on recognizing the red flags, the POST portions, as well as the birth, the yellow flag options for patients' symptoms, and encouraging them, educating them to seek care as appropriate. I don't know what it is. So almost all of our hospitals are currently have embedded post-birth education and training, both for patients upon discharge, but also for your staff. And we want to help that continue. We know that our emergency departments, our EMS services, and our outpatient OB family practice clinics really want this information too. So here it comes. You will get a follow-up email yet this week from us that tells you how to register, how to share it out, how best to use those seats so that you can use them far and wide at your facility. But you will either get 2 or 3 free seats or free registrations. And we want you to use those by this summer. We'll send you information about how to track who you've trained and the stuff that we've done before in terms of how to get on and making it as easy as possible. But we're really thrilled and thankful for the financial support to get to do this because we know the value added, especially in the updated post-birth education that's through A1 now. So stay tuned for more information on that. Next slide. Cuff Project. So the Cuff Project across Kansas, that bottom left graphic that talks about how do we improve response time for hypertensive emergencies of our pregnant postpartum patients across the state. And we know that it's going to take education, both of clinicians as well as patients. We know that it's going to take more resources, meaning putting cuffs in hands and accurately being taken. And we know it's going to take post-birth education. So despite the blood pressure, what are the patient's symptoms? And so we are excited to announce that 7 sites, have now kicked off a pilot project where you were provided free cuffs. Many of those sites have already begun to disseminate those cuffs to the patients at risk for home blood pressure monitoring. Very specific protocol, very specific follow-up, and watching that improve outcomes so that she identifies at home, knows her follow-up, elevates care as necessary, knows the post-birth warning signs, and improves the outcome. Because why? You all now have updated your protocols so timely treatment occurs when and if she needs it, once she gets to you. She's identified quicker, preventing morbidity mortality moment. Also, she attends a site. She gets to a hospital, EMS or ED, who can recognize and treat in a timely manner. The magic comes together. Okay. On the right-hand side, this is just a reminder for those of you that may not have seen it or don't remember it. We are working with many hospitals across the state who are not on the pilot project to get blood pressure cuffs in the clinics or in the hospital setting. And how you do that and how you can make it easier for the providers to give a blood pressure cuff for home monitoring to patients is described there, specific to the KanCare population. But we're going to come back through and give you more and more updates in this next year about how to get that process going in every facility across the state. Next slide. The green hearts there are the 7 cuff pilot project sites. Again, excited that we're spread all over Kansas on purpose, really targeting some of the sites that have higher hypertensive disorder statistics, but really excited for those champions and providers in those sites to make this work. Next slide. I included this piece because it describes what I just described. Why are we putting cuffs in hands of patients? Does it matter if they don't know what to do with it? And what do we do to prevent, right, the adverse outcome? So from left to right, this talks about a patient getting in early and for consistent OB care. Does she qualify for aspirin? Is she educated on post-birth? And then if she's a candidate for home blood pressure monitoring, boom, middle graphic. What do we do with that information and what do we do to watch her? And then at the end, if she needs care, again, timely treatment at those hospitals because you guys are doing that perfectly. Next slide. All right, Carrie, I think this is you, friend.
Like, oh, it's mine. It's mine. Okay, OB simulations. We are working with numerous organizations throughout the state to ensure that simulations will take place through all of our hospitals, both birthing and non-birthing. What we're waiting on is the final collaboration, a big schedule to set up with our sites of who will go when and where. So the intent is for us to start that. We're going to call it spring of 2026, so March, April-ish. I don't have exact dates on that, but just know it's getting closer. And I'm very excited. This is something I'm insanely passionate about. So stay tuned for the next steps on that. It's coming. Next slide, please. Okay. If you have not sent me a breastfeeding, pumping, expression protocol, please make sure you do so. I do have several facilities so far, and we really were previously focusing on the hypertension protocols. But now we're at the stage where we want to make sure we are looking at those as well. I just want to call out, you do not have to have a specific pumping protocol. And in many cases, it's embedded in a protocol that could be care of the newborn or neonate or any of those. If you are talking about what to do with those patients who have to manually hand express, if you have a baby who is being sent to the NICU, special care nursery, any of those, and is not staying with mom immediately after delivery, we want to make sure that you have a plan established so that we can get lactation facilitated. So if you have any questions about it, reach out to me, but I'm asking that each of you go ahead and get those protocols sent out to me as soon as possible so that we can review that. Next slide, please. Transfer protocol. I know that a lot of you got most of you actually should have, in fact, all got your what we call report cards from Michelle, and you'll notice that our transfer protocol pedal on the report card is blank. That's because we haven't approached that yet. So we just wanted you to know that everyone's is blank on that. That will be coming in 2026 as a piece of this bundle that we'll be focusing on. So stay tuned. Next, please. Severe hypertension protocols. You go ahead and go to the next slide for me, please, Tiffany. I just want to highlight that 11% of the hospitals where criteria was met reported 90% or greater of their patients being treated within 1 hour after identifying a hypertensive emergency. The reason why I skipped past the protocol is because all of these things that we are measuring in metrics are the things that should be embedded in your protocol. The timely treatment, how to treat, how to identify, and then still missing many protocols from our hospitals throughout the state. Next slide, please. When we're looking at timely treatment, we wanted to highlight what that criteria looks like. So what percent of your patient population received the appropriate treatment within 1 hour? It's not within 1 hour of them hitting the door. It's within 1 hour of them meeting the criteria of needing treatment, which at the bottom is highlighted. You have 2 readings 15 minutes apart of 160 or over 110 on your blood pressures. So I feel like there's been some confusion too amongst some of you of what that means. What do you mean they have to be treated with 1 hour after the first pressure? No, so we just want to make sure that you remember what the criteria for that response is, as well as remembering if you don't have a patient that meets that criteria, then your response to that is NA. You haven't met that. So it's not that you're failing that, you just haven't had the opportunity to meet that criteria. Next slide, please. Here's where we want to, one of the many times during this meeting that we want to open it up. So 2 things. One, I want to ask, for those of you who haven't sent me your protocols, and I do believe we have a slide in here that'll talk about, that might actually call out those of you who haven't sent it to it, yes. But for those of you who feel like timely treatment is not happening, I want to open it up to what you think those barriers are. And it's a completely safe place. I can share with you that things that we've come across could be something as simple as pharmacy. If a patient hits the door and we have tried to get her admitted, but pharmacy doesn't have her meds, so I don't have it available to give to her yet, that could be one example of a barrier of why we don't have timely treatment. But I wanted this to be an open opportunity for us to figure out what's going on in the state to where we are not meeting that with at least 90% of our patients. So who wants to be my brave soul, who wants to speak up or put in the chat what you think it is that's a barrier to timely treatment of our patients?
I could speak volumes on this for days and days.
I love it.
But we will start with the fact that it seems like it's taken us some time, and now I think we're getting there, but just to get this process, just like you said, 2 readings 15 minutes apart. Because first that's what we were told, and then, when you look at the criteria, it's no, it can't be that close, it has to be 4 hours and whatever. So I think just getting the protocol down so that everybody's aware of that. And that includes the providers, which is likely possibly our biggest, Tara's already nodding her head over there, probably our biggest thing is that's not how they've done it. That's not how they've taught. Thankfully, I've got a brand new provider who's only been here for a few months. She knows what it is. I have a provider who's been here for 9 years. She's going back to the way we did it in residency. I have ER providers, Tara, who try to tell me that they can't have preeclampsia because they aren't pregnant. Tara got an email about this one last week. So it's like, okay, come on, you guys. Yep, we've got to get into this century. We've got to get into this year because we just continue to see more and more and more. It's not going away.
I see some responses in the chat
Yeah,
too.
I see them too, Carrie. Before you read those, because those two are exactly what we keep hearing across the state. So thank you to those champions who mentioned it, as well as you, Jackie. Hey, Jackie, what you're mentioning, there's also been a couple of hospitals across the state that Carrie and I have talked to that are having issues with the postpartum piece, right? Is there a change? When does that change happen? And tightening that up. Guys, I think one of the slides that we included is that CCM, it has the algorithm of antepartum, postpartum, all of that is really simple to share out. And if you run into any of those, just like Jackie did, please don't hesitate to reach out to Carrie and I, and we will send that sucker or give you the website so that you have those resources available. But the postpartum diagnostics and the fact that it's the same protocol for X, that's helpful to hear that that's part of the story.
Yeah, and they've got it all. I even sent it over to our convenient care as well as all of our providers over in the clinic. Just because if you don't know when they're going to show up, whether it's they come into walk-in care because they have a headache, and then EMS and I, our director over there and I have been talking about it a lot. It helps to have a daughter who's an EMS, an EMT. It also helps to have a daughter who's a nurse practitioner over in the clinic, who's also an OB nurse. So we'll get it done, but it's those providers that are like, that's not how we've been doing it. I know it's not. We don't have to start MAG on every patient, I promise. Plus, it's not going to do any good. Could you just give me an order for some blood pressure tests?
This is Kim from Stormontvale on the Topeka campus. I've been able to talk to Michelle and Tara about a couple of ours, so I always appreciate their feedback. But similarly to what it looks like the comments might be is our two biggest barriers are either A, when we do have two blood pressures 15 minutes apart, we continuously take them. So it's still going off every 15 minutes while we're getting the order put in, grabbing the meds. So sometimes when we get back at the bedside, we've now had at least one, possibly two, depending on the time frame. I'll say non-hypertensive blood pressures anymore. And so our providers will use their clinical judgment and make their choice to not treat now that the patient is more normotensive. So that's probably our biggest area. Second to that is, again, like the comments say, sometimes it'll be like immediately pre-epidural. And so they're sitting up for their epidural. The provider will say, like, let's give her a few minutes, epidural's in, and of course it comes down. Or even if it's a little high, if they're kind of labile, they'll not necessarily want to push IV meds and then make them hypotensive post-epidural. And so there's kind of a balance there. But I would say those are our two areas. Either patient comes down on her own or epidural is being taken into consideration for worrying about the hypotensive efforts after that.
Hey, those are good.
Carrie, you want to read those that are on just in case people haven't seen them? And then while you're looking through that, hey, Kim, also, I wondered about the pharmacy story. If you want to talk about that, I see it mentioned here too, so we can have somebody else speak to that. But I think there's some pharmacy stories across the state too happening in terms of what's allowed to be ordered and what formulary and getting to it. So
Yes.
Not to put you on the spot, but do you mind talking about that?
I don't mind at all. So hot topic is that we have a standing order set and it allows for different medications. So like hydralazine IV, labetalol IV, things like that. Well, Joint Commission does not allow you to have two medications for the same PRN indication. So currently our standing orders just say PRN hypertension and have the blood pressure parameters there to be given. And then in the administration instructions, it will say, notify provider if, sustained hypertension 10 minutes beyond treatment for order for the other medication. So it's kind of like which came first, the chicken or the egg. Our labetalol orders will say, contact provider for hydralazine, and then our hydralazine says contact physician for labetalol. So it feels convenient. And I know our providers like to have both options in the computer at the same time. But Joint Commission considers that, rightfully so, duplicative therapy. And so unless all the providers are in agreement that every single time we always want to start with labetalol and then switch to IV hydralazine, or vice versa, whatever they totally agree on, we could do that. But due to chronic hypertensive patients being on different meds, different amounts of meds, if someone comes in and they're maxed out on PO labetalol, starting with IV labetalol is probably not the best plan of care for that patient. Well, that's what our standing orders have, not the best appropriate care. So that's kind of our hesitation on saying, like, if labetalol ineffective, move to hydralazine and actually have that, I'm going to air quote this, you can't see me, pecking order in place. So our process is you select one, and then if you need to go to the other one, one has to be discontinued. So you can only have one med at a time with the PRN indication of severe hypertension. So I know that's a lot of words. I tried to describe it without confusing, so I really hope that worked. But that's our biggest barrier as far as getting the meds timely to the patient. Having those available in our standing order set is actually what works well, which is why we like having them all there and available. So that way you pre-check it, pharmacy approves it, you grab it, and it can almost always be given within 10 to 15 minutes. It's more just a matter of having the different options available at the same time for when you're wanting to switch therapies mid-treatment.
Yeah, Kim, that's what I needed you to say. Thank you, ma'am.
I'm glad
Carrie,
it went.
yeah, I was feeding you on purpose. Carrie, do you want to jump on what they're saying in the chat, or you want me to?
Yeah, no, I feel like one example given was nurses are not thinking it's a true blood pressure due to pain, which coincides again with the next one. Our two fallouts were gestational or chronic hypertension and giving the patient time to calm down before retaking. Another, my provider is getting better, but they tend to go right to MAG or give her an epidural. I've drilled this into our nurses to ask the provider, which antihypertensive do you want us to give first? I do love you. So great examples that we know there are many things that can impact a patient's blood pressure, including, are we using the right size cuff for her? But I appreciate the concept of, do we have it on serial blood pressure readings just until we can rule out that these are her true blood pressures, and try and establish what this is. Is she hitting the door for the first time, or is this someone who you've already established what her baseline is, and now you see some abnormals? I think all of it is legit. I feel like there's a theme with the concept of Joint Commission, pharmacy, all of those components to it too. So it's not, we are not suggesting in any way it's an easy fix, but we are saying that we are sitting at the table with people asking us what the barriers are so that we could perhaps take that back and see how we can start addressing it. So all of this feedback you're giving us is really important, and I appreciate it. Does anyone else want to share?
I think where you talked about whether or not we were calling it, chronic hypertension, or we're taking it and we're like calming down, calm down. I think one of the things as I listen to podcasts, I have a lot of drive time, 2 hours every day, is to stop normalizing the abnormal in pregnant and laboring patients. Is to stop saying, well, she's in pain, so that's why her blood pressure is 160/95. No, it's not. And you got to look at that. You have to stop normalizing the abnormal.
I think this is Tony at Neosha Memorial. So we've had a couple of instances where we've had a chronic hypertension that's being treated in the clinic. And when they got to us, which is a walk through the hospital, and then we obtained maybe a couple that were very borderline. And so truly, is this part of her chronic hypertension that needs adjusting, or is she truly in severe hypertension? So that's kind of stopped us in our tracks a couple of times. And then I think the it's odd when they get high blood pressures in the clinic, they send them down to OB for severe hypertension treatment, and they get to us and they're not hypertensive. It's like, I don't know, is that education that needs to happen in the clinic? So anyway, I think those have slowed us down a couple of times, but overall, I think we've done pretty well.
Anyone else? Okay. Tiffany, if you'll go to the next slide for me, I appreciate you all for contributing there. Just want to remind you for exactly what Tara was saying, for those of you who need that extra resource to take back to your facilities, just remember we have access to all of those on the website that remind us of what the treatable ranges are and what the criteria is and how to go about. And even so far as to once we normalize the blood pressure, what is the monitoring parameters supposed to look like? So just remember we have access to all of that on our website. Next slide, please. Related to our policy and procedures, 65% of birthing hospitals have submitted policies to contain best practice models for maternal early warning signs, diagnostic criteria, maternal monitoring, and treatment of severe preeclampsia and eclampsia. Those are the primary things that we are looking for. I may have sent back little notes here or there to facilities to say, have you considered this? How do you guys handle this? Just to make sure we get the wheels spinning and make sure everyone's thinking of all the components outside. Next slide, please. Amongst the 40 hospitals that had patients meeting the criteria, 65% of our facilities had our policies reviewed, 35% of our facilities have not had our policies reviewed. Next slide. And these are my birthing facilities that have not yet submitted to me their hypertension policies or procedures. So I ask you to please make that a priority. If you do not have a policy or procedure and that's your barrier to why you haven't submitted it, please reach out to me so that we could work together on seeing if we can get one started for your facility. I always feel like this is the groundwork. You have to have something that tells your staff how to handle that situation when that patient walks in the door. So please make sure you reach out to me. If you have one already, let's get it sent over. If you're on the list and you think you've already sent it to me, just resend it again. For my non-birthing facilities, I haven't asked you up until this point to send it, but we do now that we've sent out all the resources and we've talked several times about what should be incorporated into that. I do want to make sure our non-birthing facilities have established a policy or procedure at their facility on how to handle that too. And I ask that you email that over to me as well. Again, if you have any questions in the interim, reach out. Happy to go over it with you. Happy to set up a meeting to talk about what it should look like again if you're building one. But this is really, really the foundation of what this bundle should be laid upon. Next slide, please. Okay, looking at the data related to our postpartum blood pressure checks. I think there was some confusion, I think, with this over who has to be seen within 3 days versus who has to be seen within 7 days. Let me reassure you, I also was confused. You can always do more, you just can't do less. So among the 36 hospitals that had patients meeting the criteria, and the criteria is what percent of your patient population with gestational hypertension, preeclampsia, or eclampsia on current admission had a scheduled appointment at 3 days. So it has to be upon this admission that they had one of those 3 diagnoses when they follow up in 3 days. If they have a chronic hypertension or they were not diagnosed with preeclampsia on this hospitalization, but they had abnormal pressures, those are your 7-day follow-ups. So there's your statistics or data amongst our hospitals of who fell between what. Next slide, please. I think this might be a duplicate slide, so we're going to skip past that. And Tara, I'm going to hand this one back over to you.
You guys also, we will talk through after we finish a couple more bundle items, we're going to talk through the data collection. And what you saw in the slides that Carrie reviewed, we have dug and dug and dug and talked to many of you about how does the data not show what we know is happening at your facilities? Tony, you brought up a great problem. in terms of timely treatment. And what if midwife Stroda found an abnormal blood pressure and I shot her over to you in the inpatient setting and blood pressures are normal? Like, how does she count? Anyway, lots of questions that we're going to try to answer here in a little bit. But let's get through a couple more of these important bundle items that are really vital to the bundle as a whole. Because as you all know, yes, we're focused on severe hypertensive disorder and related emergencies, but that patient comes with a lot of things. And we want to make sure we unpackage all of that. You all have been working for several years on a project we've called MAVIS surrounding intimate partner violence. We know that you all can't fix all the things, though we ask you to fix all the things in the inpatient setting. We ask that you continue to work on your IPV workflow and what we're calling now the community partner agreement. I will come back with more information. We've got our MAVIS group and team that wants to help all the hospitals get to the point where we have documentation of your good work. We're hearing that you have a very good workflow for how to identify, screen, and refer inpatient to outpatient with your patients that with CUES training screen positive. And so anyway, we're going to tighten that up, get you some help, and make sure we complete that part of the initiative ASAP. So look for more information in your email and warm handoff to our buddies that are helping us with the MAVIS project. Next slide. All right, here it is. So this is a busy slide, but again, really want some feedback and questions as they come. You all got the bottom graph there that starts with Dear Champions. It's in small, not perimenopausal women eyesight looking graph or font, but you all got that email that said, hey, we are ready for the next data set. Michelle sent this out to you, and that's a screenshot of that email. We want to make it clear that the highlighted portions of that survey are the only things you need to submit. If you've already been a 5, right, and completed pieces of the bundle, IPV included, you don't have to fill out those portions, and they are not highlighted on your survey. But a couple and some major big concepts that we know are being missed or maybe miscommunicated on our end. The deadline for submission of that survey, your updated data, which is the second half data of 2025. Also, remember, we always ask for your birth numbers. So at the top of that survey, very important that you put how many births for the birthing facilities. Well, not birthing. You would deliver a couple extra by accident sometimes too. But for birthing facilities, how many births did you have in 2025? And then fill that data out and submit it to Michelle, please, by February 4th. Here are some important pieces that we have learned and want to reach out and help. The timely treatment and scheduling of blood pressure checks postpartum for both a 7-day and the 3-day blood pressure checks, because those are tricky. Those of you that are large facilities were really very helpful in saying, oh my gosh, guys, I can't figure out how to pull it through on EHR. I can't get it easy to do. And I'm having to literally go through each chart that she meets criteria, figure out if she meets criteria, then figure out if we timely treated, figure out if she's a scheduled blood pressure check, and sometimes that's not documented, et cetera. And as we listened and said, okay, hold on, how can we help? We remembered lots of conversation we had with the AIM Data Center about a cohort. So if you're a hospital, you're a champion, you're a data person that's really bogged down and overwhelmed with chart pulls, please reach out to Carrie and I and Michelle. Michelle, Carrie, and I are the people that can do what we describe next. Large hospitals are welcome to pull out a percentage of the patients' charts that meet criteria, let's say for timely treatment, and report numbers. So if 100 patients met criteria for timely treatment, we might say, hey, pull 10 of those charts, dig deep, and you may report, all right, well, 9 of those charts met protocol. So I'm going to report that going back up to the 100 total, that 90 met protocol, that's your numerator, that were treated within 1 hour out of 100. So in other words, you'll pull a cohort out. We'll figure out together what percentage is appropriate based on those that meet criteria and help you figure out so you're not going through hundreds and hundreds of charts. There's no way you're going to be able to do that. We recognize that problem, and we were hoping EHRs could be figured out by now. It's okay. We want to help. So reach out to us and we'll jump in. That only pertains to timely treatment and the scheduling of the postpartum blood pressure checks. Okay, next slide. Also, what Carrie mentioned, I just want to pull out and make sure that it's as clear as possible. Timely treatment, you guys, this is a screenshot of that part of the survey. So those folks, or what we're asking on this question is a timely treatment of persistent severe hypertensive patients that meet criteria. And if you look at the middle section where it talks about the category and then numerator denominator, remember if you cannot disaggregate by race, those listed there on the left-hand column, it's okay to put the answers just in the all row, so total row. Okay, if you can decide, we want you to. That is very helpful information at the state and national level. Same for payer. So payer, Medicaid, private insurance, public insurance, uninsured. If you can disaggregate those folks that meet criteria by your payer, lovely. If you can't, it's okay. We want total numbers, numerator, denominator there. Again, if you have questions about that, reach out to us. Next slide. This slide and the next slide talk about what Carrie described. So this is the data question asking you about the 3-day postpartum follow-up. So the patient that leaves your hospital with an active diagnosis of treated severe hypertension, right? So she was gestational hypertensive prior to and during, treated for hypertensive disorder, and or had preeclampsia and or had eclampsia. That protocol is specific that she needs to be seen within 3 days. If she's seen it 1 day post-discharge, awesome. 2, great. 3, great. Okay. Now, click to the next slide for me. This is, I think, where we lost you a little bit, and I'll blame myself on that. This is the piece that we capture data on those patients that entered the birth setting with chronic hypertension but didn't escalate their symptoms. They were not diagnosed with preeclampsia or eclampsia during that hospital stay. So they may have entered as a chronic hypertensive or a gestational hypertensive, but did not have treatment in delivery, labor delivery, or immediate postpartum in the hospital. And those patients may be seen within 7 days. Now, holy moly, that's a lot, right? I will tell you that many of our hospitals just said everyone's coming in at 3 days. Or if it's a weekend, making it work so that it's plus or minus a day. That is fine. Within 7 days for this group is fine. If you see everybody at 3, you're winning at both of those data collection points. Okay. So again, don't hesitate to reach out. Offline, we'll walk through if you have some specific questions, but want to make sure we called that out because I think, Tiffany, I'm going to ask you to give us a headache here, but can you go back to the slide that talks about timely treatment and the blood pressure checks, 3 days? Keep going. We're close. There, right there. Stop right. Yep. Stop right there. It's like, what was that game show? No whammies. Okay, blood pressure. Sorry, I'm really old. Blood pressure check within 3 days. So you guys see, and on the colored graphs on the left-hand side, your January 2025 was your baseline data over to June 2025. So January to June, your first half of 2025 data. This is what you guys reported to us. Again, you're getting ready to report July through December. But it really surprised us that only 11% of hospitals that reported that had criteria met were at 90% of greater for postpartum blood pressure check follow-up. My suspect on this one is that it's hard to track it. And so we've talked to hospitals about if there's documentation from the provider that the patient will follow up within 3 days. Resource was given to the patient to call or the appointment was given prior to discharge, that counts. If she's seen in a postpartum clinic, if she's seen by a home visiting nurse, if she's seen in, anyway, lots of options for who, as long as a blood pressure check is taken in a setting that you would agree is part of your protocol, right? Then that counts. And I think that this is underreported because of the confusion. Tiffany, go back a couple more slides to that timely treatment one, or not the protocols, but maybe 2 or 3 before that. Keep going. One more, 2 more. Keep going. Right there. Bingo. Same problem here. But I believe when Carrie and I talk to sites that our biggest oh no, I think we're underreporting. Again, so many of you have told us that you have updated your protocol and that success is happening, that I'm a little surprised that we're at 11% of the 35 hospitals that met criteria. So you had patients that met criteria for timely treatment, right? Severe hypertension. Only 11% were treated within that 1 hour or hit 90% or greater. Now, big gap, right? The three, right? So 40% of our hospitals that met criteria were between 10 and 89%. We recognize that that's a big jump. You could be at 88.8%. And that was probably painful for you to report to us. But we hear you and we're watching that data too very closely, because what we're seeing is improvement all the way through. Folks are shifting from not meeting to, ooh, we're getting closer, our percentage is going up, to, bingo, we've got it set. There's always going to be some outliers, guys, but we're seeing the process improvement, but want to make sure you're giving yourselves credit. With that, oh, go ahead, Carrie.
Sorry, Tara, I just want to add on to that. Like, don't forget this extends to our postpartum patients too. So they may not be coming straight to the labor and delivery. They may be presenting to your emergency department. And that's why we are encouraging immensely, both for our EDs and our non-birthing facilities, to get this education, is because you too will impact this number. Did she hit triage? Did they recognize that that was a number that needed to be treated? Did they either treat her in the ED, or did they get her over to your unit as quickly as possible? Those numbers, those patients will impact your data there as well. So making sure that we're extending this education across the board to your hospital emergency department staff is critical.
So you guys, we have about 15 minutes left. Let's go to the end and make sure we hit the slides. And then I really want to open it up for questions about the data collection. Because again, we know that this bundle is not about data, but we also hear what's working. Right there would be perfect. So we pulled out some of a small, medium, and large hospital to show off some of the report cards that you guys got. And a big thank you to Michelle Black for her hard work. Carrie, too. You guys did so much work to make sure that these hospital report cards went back out. You all use your report cards, put it up in a prominent place to show off to your facilities and your champions, meaning all the people taking care of patients, of how well you're doing. Look at all of the things we're asking you to do. And so Amarillo Hiawatha, Chelsea James has long been a really stronghold in that hospital and doing some great things there. And of course, look at all the yellow petals. Excited to move them all to yellow, and we know that she's working hard to do so. Next slide. Newman, again, great work happening there. Another powerhouse for sure. And the unit drills is going to be a major focus for them. I know. I'd be surprised if they're not already doing some, actually. So we're excited to see that data come in for this last 6 months. Most of you are at 3 with your pumping protocol. And remember, Carrie just talked about that. So directional help, getting the protocol to Carrie, and anything that we can do to connect you with breastfeeding resources, we're happy to do as well. But excited to move everybody to 5s on that. And then last but not least, Advent Health Shawnee Mission. Again, great work happening at a very large facility, one of the biggest in the state, and certainly seeing the pendulum move tremendously. I'm having a hard time believing that the blood pressure check within 3 days is really a 1. Again, I suspect that there's some providers doing it, not all. In a big facility, it's hard to track. It's so hard to track. And that might be part of the problem, right? In terms of the follow-up that we see throughout the state. So anyway, great work for all 3 of those facilities. And if you have questions about your report card, again, reach out to Carrie and I, and we'll be happy to deep dive into it. Next slide. So questions, successes, things that, especially as you look through your report card, we want to give you some time here to ask us. The last few slides are just about our in-person workday and the registration, as well as the rest of the year learning forums, so that you get that on your calendars. And then again, that we'll meet just with the champions. Yep, there it is. Thanks, Tiffany. All the learning forums. Look at her getting you organized. Thanks, Tiffany. So again, all the links are there. Put those suckers in your calendar. This will come in your slide deck. And then that last slide is just a reminder that we'll meet just with the champions again next month. And please don't hesitate to come with questions and case studies and good news stories. But let's pause. Questions, concerns, anything from those of you that we haven't heard from, or those of you that we have other ideas?
You guys are really quiet today. It's so much better when we meet in person. We get to have these conversations with you regularly, but I also look forward to this January and February learning forum where it's just you all. And we haven't opened it up to the entire listserv because it gives us the opportunity to speak to you and to figure out how things are going along with the bundle.
I think here at Neosho Memorial, I think we've misunderstood the reporting for 3 days or a blood pressure check for 3 days and 7 days. So we were thinking 3 days were for patients that we treated for severe hypertension, but it should include, the way I'm taking it now, preeclampsia. It should be all of those.
Correct. So anybody
Okay.
diagnosed with preeclampsia, which maybe you
Treated
did
or
or
not
didn't treat,
treated.
right? Right.
Okay.
You gotcha. The
Okay.
elevated diagnoses, really. So somebody that was treated and or came to you or was diagnosed in the birth setting with preeclampsia or
Okay.
postpartum, right? Postpartum
Right.
preeclampsia is a thing. Yep. You got
Right.
it, Tony.
Okay. Sorry about that.
Don't be sorry. That's why we're talking
No,
about it.
that's
You're
why we're
not alone.
here.
Yeah.
Nope,
Hey,
that's
this
why we're
is
here.
Katie from Community Healthcare System in Onega. I don't know if I just kind of got lost in the shuffle because I feel like this has kind of went on for a long time, but I've never seen a report card. I have sent policies, but I've never heard nothing back. So I just don't even know where I'm supposed to be going from here because I don't know.
Well, Katie, I
Katie,
want to help you. We got you, kid.
I
I'll
need
follow up
help.
with
I
you.
need help.
You don't need help, Katie. You're a powerhouse. I wonder if your email is the problem on our end. I will follow up as soon as we get done and we'll get you taken care of.
Okay, that sounds fine. Maybe I've missed something. I don't know. But all right, thanks.
Katie,
This is
thanks
Kim.
for
One more quick
understanding
question. One
that.
more quick question about the hypertension retreatment. I know as an organization, our hospital looks at our timely treatment, but we look at each two blood pressures in a row as a new opportunity. So my denominator and my numerator denominator look very, very different than what I submit. So we might have a patient, like several of you, I mean, I know we're not unique to this, we'll have a patient who between an antenatal stay, delivery, and postpartum stay might receive 10, 15 antihypertensive medications. And so each one is an opportunity for us. So when you're looking at as an entire patient, sometimes the data I am submitting doesn't look identical to the data that me as person in my role or what I share with my providers, because we look at it as opportunities for treatment versus patient. It's an all or none. So I don't know if anybody else has come across that or anybody has a barrier there as well, but that will be the only thing I will say, that like as an organization, our hypertensive treatment data looks good, but when I submit it to KPQC, it doesn't look so hot sometimes.
No, yeah, Kim, and I would tell you you're not alone because I can think of two other hospitals that have mentioned that exact situation, or they had an elevated blood pressure, severe range, an antepartum appointment at 24 weeks. Never happened again, but it cued the EHR that she was, she met criteria, and so anyway, just really strange things like that happening too. We are asking almost too vague of a question. I hear you and I agree, but at the same time, we know what you're doing and we see the success. So part of it, Kim, and maybe that we just need to figure out how that data works best for you. Those of you that are facing that same problem, I wonder how we can get the report to mirror what's actually happening there, because I know that your protocols are tight. Anybody else with that same follow through? She's right, and actually, that's a great approach. We're not asking that question. We're asking
and I'm not saying you
diagnosis and
shouldn't
treatment.
change your data points. I just
Yeah.
know like our provider champions will review every fallout and we kind of determine, is it a nursing issue? Did the nursing not notify providers? And then I kind of take that on and follow up on an individual basis. But if it's providers not treating, whether it be just it's still within the standard of care versus not being within the standard of care, that kind of goes to a different approach as far as review. So I just our in at the end of the month is way higher here than I feel like I submit to you guys.
I just got a phone call. I have to go catch a baby. So, Carrie, take it from here, guys. I'll talk to you soon, and thanks for all your hard work.
actually think I'm going to use this opportunity as a wrap up and give you guys a few minutes back. I really look forward to the contributions that everyone's jumping in with. And Katie Kufal, thank you so much for letting us know that you have not been getting communication. We will definitely look into that some more. And I look forward to seeing each of you in February. Make sure you put the May 1st in-person workday on your calendar. We're coming to the table with some swag, lunch is included. We're just really excited to see everyone in person in Topeka. And in the meantime, I've already gotten a couple emails just since we started this meeting with people's protocols, and I'm really appreciative of that. So you guys have a fabulous rest of your day.
Hey, Katie.
Reach out if you have any questions. And
Can
go
we
ahead,
have
Tiffany.
Katie put her email in the chat? I just want to verify it on all of our.
Yes, that's
Thank
a
you.
great idea. Katie, if you'll put your email in the chat so we can make sure we are reaching out appropriately. And I will fish through my emails to make sure that I have not missed anything from you. Awesome. Perfect. And for everyone else, have a wonderful rest of your Tuesday, and we'll see you in February.
Thanks. Have a great day.
You too. See you Sunday, friend.
Woohoo!